Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Abbvie, Janssen, MeriaGTx, Novartis and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below. So it gives me great pleasure today to introduce you to Dr. Yau. He's here today from Toronto as well, and he is a member of the team at North Toronto Eye Care. He completed his medical school at the University of Western Ontario and ophthalmology residency at Queen's University, where he served as chief resident. He subsequently completed his fellowship in medical retina and clinical trial research at Harvard Medical School. Dr. Yau is devoted to providing the best care possible, care which is compassionate, patient-centered, and evidence-based. He's had numerous awards, including being recognized as one of the top 5 resident ophthalmic researchers in Canada twice by Novartis Vision Fund, research awards from Canadian Glaucoma Society and the Canadian Ophthalmological Society. So welcome, Dr. Yau. Thank you so much for joining us here today.
Thank you for the invite. I'm looking forward to questions, and hopefully I can shed some light on diabetic eye disease as well as other retina diseases, should anyone have any questions.
Wonderful, thank you. So yes, I have some questions prepared, but as you have questions as we go through the webinar, please feel free to send them in. We will get to as many of them as possible. So I know we're going to talk about some different eye conditions today, but again, November being Diabetes Month, we'd love to start off talking a little bit about diabetes and diabetes-related eye disease. So to start off, could you tell us a little bit about how diabetes affects the eye, specifically the retina?
Thank you. And so diabetes is a systemic disease, as we all know. And one of the effects is that there's a lot of excess sugar or excess glucose or sugar that's coursing through the blood vessels. And as you can imagine, this can be detrimental. And specifically, it starts to damage the blood vessels. And so it can cause a variety of effects. And one of the common target organs that is affected is the retina, and subsequently our vision. And in the retina is the kind of the inner lining of the eye, and its blood vessels course through it to supply oxygen to this highly metabolic organ that allows us to see. And so as you can imagine, if there's a lot of glucose, excess glucose and so forth, starts to damage the blood vessels, things start to happen, unfortunately. So leakage of blood and lipids start to populate the retina and subsequently affect vision. And ultimately, if there's not enough oxygen going to the retina tissue starts to die. Now, one kind of very important inflection point that happens within this disease called diabetic retinopathy is when new blood vessels start to grow. And this is something called neovascularization. And once that occurs, there can be potentially very severe complications from this. And so there are 3 specifically that I can mention. These blood vessels that grow, even though the intention was good that there's these new blood vessels supplying oxygen, unfortunately, these blood vessels are fragile and they bleed. And one such effect is bleeding into the substance of the eye, which is the vitreous. And the vitreous is a normally clear gel-like substance within the eye, and it fills with blood. And so this is a condition called vitreous hemorrhage. And people with this condition can be waking up one morning totally blind. Another potential effect of these new blood vessels is that they can contract and pull on the retina, causing a retinal detachment. And thirdly, these blood vessels can grow anywhere in the eye, including in the front of the eye, which then blocks the outflow tract of the eye, leading to increased pressure in the eye, damaging the nerve. And so this would be something called glaucoma. So, these are very, I guess, severe end-stage endpoints to diabetic retinopathy. However, importantly, the earlier stages, we can intervene in a sense. And so really the message here today is that the earlier we are able to identify earlier stages of diabetic retinopathy, it gives us as eye care providers a chance to intervene and hopefully subvert these more severe complications.
Thank you for that overview. That's really interesting. I didn't know that glaucoma could be a result of diabetes, but that makes a lot of sense when you talk about that pressure building in the eye. You talked about diabetic retinopathy, but another term that we often hear is diabetic macular edema. Are those two things the same? Are they different? What's that other term?
For sure. I would say that diabetic macular edema is an additional feature of diabetic retinopathy. So you can have diabetic retinopathy without diabetic macular edema. It doesn't matter what stage of diabetic retinopathy. You could have mild diabetic retinopathy with macular edema or very severe without macular edema. So what is macular edema? Macular edema is where, as I had previously mentioned, the diabetes, the blood vessels are diseased and they start to leak fluids and proteins and lipids. And there is, our body does have an ability to pump it out, but if there's too much of that leakage, that fluid starts to accumulate, and it accumulates in the center of the retina called the macula. And so there's this swelling in the center of the macula, and that center of the macula is very important because it's responsible for sharp vision, fine vision, allows us to read, clearly see faces, TV, etc. So diabetic macular edema would be the most common cause of moderate visual deficit within our diabetes population.
So you've talked a little bit about some of the different conditions that can result, but what symptoms should people be looking out for, especially if they have diabetes? What things could be sort of a warning sign of one of these conditions progressing?
For sure. I think if you do have a diagnosis of diabetes, number one, it's important to be screened, even if you don't have symptoms. And that's really an important point because even in late diabetic retinopathy, even if you have frank diabetic edema that we see clinically, you actually may not be symptomatic. So I think that's number one thing. Always get it checked. Once you get that diagnosis, I think it's important to be seen by an eye doctor. Now, in terms of the two kind of more common causes from visual deficit from diabetic eye disease, diabetic macular edema, it's a result of kind of swelling and it's relatively slow. So you may not notice it acutely that you have a visual deficit. And commonly when I see patients, it's usually because they went to see their optometrist or their primary eye care provider and just for a regular check, and they noticed that there's a little bit of a decrease in vision and they were sent to me. The other common cause for visual deficit, as I mentioned, is something called vitreous hemorrhage. And that's where it's already at a very advanced diabetic retinopathy stage and these fragile blood vessels have filled the eye with blood. And that's a little bit more obvious and dramatic. It can start with a few black dots, which are the blood cells that have leaked into the eye. And if there's enough, it basically complete haze. And even to the point where that one eye could only see hand motion, for example. So that's a very obvious presentation. And certainly any time you have acute vision loss or sudden vision loss, it should be seen in an emergent manner. Yeah.
So I imagine with diabetes just generally, like the most important thing is to keep a good control over blood sugar. And I assume that that applies as well for sort of the development of these diseases. So keeping control of blood sugar, are there other things that people can do to help prevent these conditions from developing?
Yeah, and I don't think, so you said the foundation, which is controlling blood sugar. And I know that can be sometimes maybe, it might be too abstract. And I've found it, and I've said it many times, and it doesn't seem to register as well. And so throughout, I've kind of tried to find other ways to emphasize that because it is the most important thing or the biggest impact. And so I do like to, I think it's very important to educate a patient and take ownership of the disease. And so when we talk about better diabetes control, sometimes giving a very specific metric can be helpful. And one common metric is what we call HbA1c, which is kind of a measure of average blood sugar for the last 2-3 months. And yes, it's ideally it'd be less than 7%. But the reality is that most people with very advanced diabetic retinopathy, they are advanced for certain reasons of being unable to control their sugars for a variety of reasons. And it's not uncommon for their A1C to be in the 10 to 15% range. And so to tell someone to go under 7 is very daunting, certainly for the initial consultation. So I like to use another statistic that came from the same study that showed a lowering of 1%, an absolute lowering 1%, can decrease progression by about 50%. So if you go from 14 to 13, 13 to 12, that's, seems a little more attainable, but with the very, very important impact. So that'd be the first thing. The second and third things that are also important medically, and that this is where a team is important, is certainly blood sugar, blood pressure, as well as cholesterol control. There's shown studies that has an effect. And then in terms of, once again, kind of making it realistic and practical, exercise is important. And if you walk, 15 to 20 minutes a day, that is effective. So I think that's attainable for most people. And certainly smoking, if that's a habit, then beginning that discussion is important. And I'll say one more thing is compliance. And so what that means is coming to follow-ups. There is no one fix for this. So when somebody comes in with this, there isn't a one treatment. It is a series of treatments that can last years. So I think it's important for me to emphasize that, or all eye care professionals, as well as their whole eye care professional team, to say that this is a journey that we're with patients with, and to kind of understand that this is a process. It's a chronic disease that requires chronic treatment, and trying to get that buy-in is very important.
Thank you so much for that response. And I think that the first part about blood sugar is a really interesting way of putting it. I've never heard it put that way before, but that statistic of bringing it down just 1% is really quite significant. So that, like you said, I think people might feel more that's more attainable than just thinking, oh, I have to get it down, 7 or 8%. Mm-hmm. So the next question is sort of I guess a two-part question. So once you have you've been diagnosed with diabetic retinopathy, what treatments are available for this condition? And are they just to prevent further vision loss, or is there any reversing vision loss that might already have occurred with these treatments?
That's a really good question. And I'll start with, in the last, which is encouraging for many people that suffer from this disease, there's been a dramatic change in the last 1 or 2 decades for treatment in a positive way. That factor and it's really because of the identification of that factor that leads to leakage of fluid from the blood vessels, that leads to these new blood vessels growing. And that factor was isolated to be something called vascular endothelial growth factor, so VEGF. So if you're able to kind of contain that, which now we have medications to do that, it downregulates that downstream effect. And so it really has changed the way we treat diabetic eye disease. And so the first line treatment for diabetic macular edema would be, and if it's visually significant, it would be injection of this medication into the eye. Now, before that, there were other treatments, which would include laser, as well as steroids that were injected into the eye to treat the anti-inflammatory component. And those are still in our armamentarium. They do have other, a certain side effect profile, so they're not our first choice, but they still can be shown to be effective in select cases. I think the key point is it's always good to have more options now. And so that's to answer your question. Interestingly, you mentioned about reversal. And that's an interesting concept because there's studies that show that down-regulating or kind of decreasing the VEGF load, this vascular endothelial growth factor load, can actually make a reverse retinopathy. Now, it has yet to be shown if this is a sustainable effect, but how I use that in clinic is that when somebody comes in with kind of a moderate diabetic retinopathy, once again, another way to encourage them is that I tell them that you're kind of at a fork in the road. And if you are able to make some changes to your lifestyle and so forth, your disease can potentially reverse. And that is an encouraging fact for a lot of people, yeah, that I've found.
Absolutely. I think that gives, even more hope and people go forth with these treatments, because I know, I work at our health information line too, and a lot of people contact me when they have questions about some of these things, and people have a lot of, I guess maybe fear or anxiety around getting injections in their eye. Can you talk a little bit about that process and what that's like for people?
Yeah, so that's definitely the hardest sell for sure, and it's not trivial, because if that is deterring someone from coming to their appointments, that can be very detrimental. And so I think I start off by saying, this would be our if that is the selection of treatment, I start off right away saying, don't worry, it doesn't sound as bad, or it doesn't feel as bad as it sounds, because I know that's the first thing that comes into everyone's mind. We do have very effective ways to anesthetize the eye in a very non-invasive manner, and I would say it's tolerable. But I understand that trepidation, and so I believe one of your further questions would be what's in the pipeline, and I think there's a recognition that this is a barrier to treatment, and so there are many groups looking at decreasing that burden. So whether it be longer acting agents, so you won't need as many injections, or a medical device that can slowly elute the drug, once again, to decrease the amount of injections. People are working on that. And I do think that it's important to kind of emphasize that, again, 10 years ago, we didn't have this, and now, or 15 years ago, we didn't have, now we do. And to also emphasize that 10, 15 years from now, there'll be other things, or even more in the near future. So I think saying that is important. Yeah. And but there's no going around it. It is kind of a scary thought initially. Yes.
Is the purpose, I guess, of the injection just to get the medication as close as possible to sort of the retina, the source of this extra bleeding?
That's right.
That you couldn't really get through like oral medication or a different kind of injection.
Absolutely. And it's not that people haven't tried, because that would be a more desirable route, topical drop or an oral medication. And there's still active research in those routes, but so far that has been the most effective route.
Yeah. So you've talked about these medications, and I know if there's anyone out there in the audience who've attended any of our webinars about age-related macular degeneration, for instance, these drugs are also used as a treatment for AMD. And we know that there's several different drugs, and that patients they don't always have the same injection frequency, I guess. So depending on the person, those injection frequencies might change. So, as an ophthalmologist, when you're seeing a patient, how do you determine sort of which medication to use, how long those intervals between injections are going to be?
Yeah, so specifically for diabetic retinopathy, there are we have the advantage of having multiple agents available to us within the same family. So I think in general, when I say first line, it's that family of medication. There are specific nuances in terms of what we use, but at the end of the day, it does require frequent dosing. With respect to diabetes, another important piece of a line that I say, which is supported by evidence, is that evidence typically shows that most of the treatments for most people can be in the first year. and they do tend to taper off. And so that's also an important kind of thing that maybe for some people it could be a finite amount of treatments. And so that's another line that I use that's important, because as a patient kind of putting their shoes, it's good to know that there's might be a more finite treatment strategy that can have permanent positive effects. Unfortunately, for wet macular degeneration, other diseases, it does require a kind of more long-term treatment. Yeah.
Absolutely. So I'll see if there's any audience questions about diabetes. We can take all the questions at the end, but my last question would be, so if you have diabetes, so far so good with your eyes, how often should you be seen by an eye doctor? And it should be seeing an ophthalmologist? Can you see an optometrist? What's the best strategy just to keep on top of it?
Yeah, for sure. So, I mean, the guidelines are, I'll say what the guidelines are. So if you're diagnosed with type 1 diabetes, typically you're young, and you don't necessarily, and it takes time for diabetic retinopathy to occur. So, but I think in general, just to keep it simple, I think if you have a new diagnosis of diabetes, you should be screened as a baseline. And depending on that severity level of diabetic retinopathy, as well as whether or not plus or minus you have diabetic macular edema, that changes the follow-up schedule. But if you have mild diabetic retinopathy, for example, or no or mild, it can be seen every 9 to 12 months, for example. If you require some level of treatment, and that can be seen by an ophthalmologist or your primary eye care provider, once you require treatment, you're going to have to see a physician that's trained in treatment. And again, this requires either injections or laser. And the frequency can vary based on, how severe that thing is. So it could be every 1 month, it could be every 3 months, for example. And then if you're kind of in the middle where you have, let's say, moderate diabetic retinopathy, but you don't have anything to treat, you could potentially see someone between 4 to 6 months. Yeah, but I think for a vast majority of cases, I think if you have diabetes and you don't have any visual issues and it's been confirmed that you kind of have no to mild, typically every year with your eye care provider, whether it be an optometrist or an ophthalmologist.
Great, thank you so much. So I'm going to move on to some other sort of retinal conditions. But again, if you have questions at all about anything we've talked about so far, please feel free to pop those into the Q&A or email us at education@fightingblindness.ca. So another condition that I get quite a few questions about actually through our health information line is retinal artery or retinal vein occlusions. Could you talk a little bit about those, what they are, how they're different from each other?
Sure, for sure. And it's definitely one of the top 3 diseases that I see. So I mentioned previously that the retina is, there's blood vessels that course through it, because it's a highly metabolic tissue that allows us to see. And so the artery supplies oxygenated blood, and then the retina absorbs that oxygen and uses it, and then the blood that's kind of passed through now, deoxygenated blood, gets out with the vein. And so I mention that because there is a very important distinction, because if a retinal artery gets occluded, all of a sudden the downstream tissue that was relying on that oxygen does not get oxygen and it dies. And so the symptom is acute vision loss. And unfortunately, in a majority of cases, it's permanent. And unfortunately, we just do not have any good treatments for it. And this is characterized as basically it qualifies as a stroke. It just so happens to be in a very defined area of the body with a very defined symptom. And so with that, if someone comes to me with this condition within 24 hours, we do have to treat it like a stroke, in that they have to go to the emergency room. They have to get the appropriate stroke workup because they are at immediate risk in the coming weeks for other cardiovascular events, such as heart attack. So that's a little bit, so that's an artery occlusion. A vein occlusion has a little bit of a different underlying pathophysiology, but basically, if a vein is blocked, this leads to I like to say a vein burst. And so what happens? There's a lot of blood that's now resident within the retina tissue, and if it's a lot, the retina cannot pump it out as much, and so swelling occurs. So macular edema also occurs in this condition, but from a different mechanism. However, it's not as it may not be as severe as a retinal artery occlusion because it's not necessarily taking away a lot of oxygen from the tissue, but initially at least it causes visual deficit by edema or swelling. And this can be effectively treated as well with these anti-vascular endothelial growth factors. That being said, if it's not treated or not seen after a long time, it can also lead to very severe vision loss. So those are the two distinctions between artery occlusion and a vein occlusion.
And then just to clarify, when you say occlusion, is it like a blockage? And what is causing that block?
Great question. And that's by and large for an artery occlusion. It's from some type of emboli or thrombi. And commonly it could be from cholesterol plaque within your carotid arteries that go up. And this is a common cause for stroke. But for this situation, it kind of occluded a vessel, an artery that supplied the eye. So that's common. Other common causes include emboli that are created within the heart. And so when we talk about a stroke workup, that would include looking at the arteries within the neck, doing some heart tests. And then there's other causes such as blood-related pro-coagulative factors. So in select cases, you would send off a blood panel looking for these factors. So there's a whole list, and then vasculitis would be another one. So there's a whole list of potential causes that can occlude a artery. Now, in terms of a vein, there's also causes as well that may be similar to those, but actually one of the probably the most common cause is veins typically are attached to arteries. And as the artery gets thicker and thicker, most commonly due to atherosclerosis or hypertension, because that high pressure and that buildup makes the lining of the artery very thick, it starts to squish and occlude the vein, and then that vein gets blocked, and then that's what happens. So that's the most common underlying reason for a vein getting occluded. And so the most common demographic for someone with a vein occlusion would be someone in their 50s or 60s with hypertension or blood pressure issues. And so when you talk about investigations for those, if somebody comes in with that type of demographic, we typically don't pursue any further investigations. But if somebody comes in with a vein occlusion that's in their 20s and 30s, we do have to pursue other underlying causes.
So you've mentioned high cholesterol as being risk factor, high blood pressure, hypertension. Are there other factors, or who else might be at risk for these conditions? Like if you have another eye disease or you have other diseases, does that make you more likely to have this condition?
Yeah, great question. I think those would be the most common ones, cardiovascular risks. When you talk about the more rare situations would be, intrinsically clotting within the bloodstream. And so those would be disorders that lead to where you would more likely coagulate. So patients would include patients that are pregnant, maybe patients that have malignancies, patients that, so those would be kind of special populations that we would pay particular attention to.
Now, earlier you mentioned that, I believe, and correct me if I got this wrong, but I think you said that for retinal artery occlusions, there's really no treatment at this point. Retinal vein occlusions, if they're caught early, could be treated with those anti-VEGF drugs. Are there any other treatments or things that people are researching, looking into to help treat these conditions?
Yeah, so artery occlusion, yeah, I mean, there have been many things that have been attempted. So I don't necessarily want anytime you have sudden vision loss, you have to be checked. And I would say if somebody comes in with that, I would try everything possible, because the alternative is, they're going to go blind. So sometimes we use maneuvers to, for example, massage the eye to maybe dislodge a clot if that's there, sometimes lowering the pressure in the eye. Other groups have even attempted hyperbaric chamber to kind of increase the oxygen tension within the eye while the body tries to clear the clot. And so other have tried even for stroke, for example, there's clot buster agents that do come with their associated risks. So that obviously has to be balanced. But I think those are the main things that are being attempted right now. Most other things are more in the experimental research stage right now. For vein occlusions, anti-VEGF is extremely effective, but it carries the same limitations such as burden of disease. I have a lot of people where I have to treat frequently to keep their vision, or else it just bounces back. The swelling comes right back. So that's probably the biggest treatment barrier there. We have a treatment that works for vein occlusion, the macular edema from it. But the question now is, can we find longer acting agents and maybe something that's more durable?
So with vein occlusion, is that then like a lifelong treatment, or yeah, how does that work? Is that sometimes stop, or is it?
Sometimes it does, sometimes it doesn't. And so I can't tell. So when someone comes in with this condition, I say you can fall into one of two camps, and we'll only know after a series of injections, seeing how it behaves. There's probably an element of the body taking over. So again, this blood vessel, this vein has been damaged, and it's leaking. And depending on the level of damage, the extent of damage, the body may be able to recover it. And so it just needs a little bit of help from the medicine. But if it's too severe, then it requires a constant suppression of that factor. So again, still a very active area of research there. But yeah, some people I'm able to taper off. Others I'm treating longer term.
Thank you. So I'm going to leave it there for the retinal and arterial vein occlusion. Sorry, retina, arterial and vein occlusions. And I'd like to talk a little bit more about retinal detachment. So you mentioned that earlier as a potential complication of diabetes-related eye disease, but it can happen for a variety of reasons. So can you talk a little bit about, who's at risk for this and what's happening in a retinal detachment?
Yeah, so what's happening in retinal detachment is, once again, the retina is the inner lining of the eye, and it's kind of like the film of the camera. So light goes in, and then there's light-sensitive cells that get that image, process it, and then transfer it through the nerve to the brain to interpret it as an image. So this layer is almost like the wallpaper. And a retinal detachment is where that wallpaper, the retina, falls off. And so there's a variety of reasons, as you mentioned, one of it being what we call tractional, so something's pulling from the inside. The more common cause of retinal detachment is that there's some type of opening within this layer due to a variety of reasons. And once there's a hole or a tear within this retina layer, then fluid in the eye can go in. And if there's enough fluid, it can start to peel off. And so who's at risk for this? We say people that are myopic, for example, myopic meaning you're nearsighted. And people that are nearsighted, their eye is just on average longer than most people. So just to give you some perspective, an average eye is about 23 millimeters in diameter. A myopic eye can be up to 30 millimeters. So it's an extra 7 millimeters, but that extra length anatomically, for whatever reason, predisposes someone to more tears. That's important. Another risk factor is somebody that may partake in more kind of head trauma related issues, such as if you're participating in full contact sports, martial arts, those may be at increased risk. There are certain genetic predispositions. Certainly someone with a family history of retinal detachment probably has elements of what I just talked about that also predispose somebody to it. And then probably another common underlying cause of that tear is something called a vitreous detachment. And the vitreous, as I mentioned, is a gel within the eye. And that gel, when we're born, is a clear gel. And so with time, that gel goes through all types of changes. It liquefies, and then it eventually peels away from the retina. And that event happens once in everyone's lifetime, when you're 60 or 70. And by and large, more than 95% of the time, it's a normal process. It peels away. Some may experience some flashing lights. Some may experience some floaters. But that is a one-time event that can, if it's stuck on enough and it peels the wrong way, it can actually rip the retina. So everyone is at risk for retinal tear and subsequent retinal detachment when that vitreous peels off. So I think the next question will be what to look out for. And so, as I mentioned, if there is a rip of some sort, there may be these cells that are liberated, and you may experience them as floaters. So a little plume of floaters. And if, let's say, it rips through a blood vessel, you might see some haze as well. And any type of stimulation to these light-sensitive cells in the retina can cause some flashing lights. So especially if you see some black dots with some quick flashes of lights or an arc of light simultaneously, that's a pretty specific symptom of a retinal tear. And then if that quickly evolves into a retinal detachment, you're going to see an area that's missing in your vision. So kind of a classic presentation for retinal detachment is coming in with an area that's missing your vision, coming from the outside in. It's kind of grayed out, and it was preceded by some flashing and floaters. And if you're telling me that you're highly myopic and your father had a retinal detachment as well, then that's on the phone, that's a reason to come in right away.
So can we talk a little bit more about floaters? I get questions about floaters all the time. You touched on them a little bit there, but I mean, does everybody have some degree of floaters? What is that happening in the eye there?
Yeah, so what floaters are kind of, let's say, clumps of collagen within the vitreous. So the vitreous, once again, is a clear substance in the eye. It's 99% water, but what makes it kind of gel-like are these collagens and other such proteins. And with time, it's a dynamic structure, and it goes through all types of changes. And so collagen can clump together, and then so when light comes in, it can cast shadows. And so that's why floaters are described as these little black dots, squigglies, that can move around. And when you move left, it kind of wiggles, and moves right, it kind of wiggles. And so surprisingly, though, it's dependent, it is very dependent on the patient. Because I'll tell you that if you look in anyone's eye under the microscope, if you were an eye, you'd see all types of debris in the eye, but not everyone experiences floaters. So it's something that isn't that well understood, unfortunately. And there's probably elements of physically there's something in the way, but there's also probably elements of neuroadaptation. So because everyone has certain levels of opacities, but not everyone experiences it, the brain must have an ability to cancel those signals out. And so, yes, floaters, I see people coming in with floaters many times a day. And the number one thing I do, because it's also a symptom of retinal tear, for example, I make sure I rule that out, that there isn't a tear that's causing these floaters. But if once that's ruled out, I mentioned that, floaters inherently are a common symptom, and they're not inherently dangerous. And by and large, I would say many people have it, but very few are necessarily debilitated by it.
That's really fascinating. So I guess just going back to your previous point is that if anyone experiences sort of a dramatic increase of these floaters too, though, that is kind of a warning sign that something is going on.
Yeah, for sure. That's a great point, because I think a lot of people may have baseline floaters, but if there's, and this comes with just a lot of conversations with patients, like the very specific symptom is a plume of floaters with flashes at the same time. And if you understand why that happens, like if there's an acute rip or sudden rip, that's going to be the symptom. But a small change in the shape of an existing floater, I would say that's probably less specific. It still warrants a check, though, but probably the more urgent thing is if there's, boom, a big plume of floater with flashes at the same time. Mhm.
And if someone experiences that, you would classify that sort of as an ocular like emergency, like people should be seen pretty
Yeah,
rapidly.
yeah, I would say just to simplify things, I mean, I would say any kind of acute change in vision should be seen by somebody that can check your eyes, yes.
Great. So what was my next question? Oh, I was going to ask, so if there is a retinal detachment, are there treatments available? Does the retinal detachment always result in a permanent loss, or are there ways to fix that detached retina?
There's certainly ways to fix the attached retina, and they can range from an in-office procedure all the way to intraocular surgery. I think in terms of what can potentially change outcome would be number one, if that retinal detachment starts to, or when it presents to the treating physician, if it already affects the center. So if it already affects the center, the retina is already lifted off the center of the retina, which is responsible once again for that sharp vision. The outlook is not as good. And then the second important factor is when that does occur, the time with which you seek treatment. So if it occurs, but you're being seen within 24 hours, that portends better than if you leave it for a week or so. So really the message is any symptom, it should be any vision loss should be seen immediately. And then when you talk about the precursor lesion being the retinal tear, if you see flashes and floaters, that should be identified early, because if you can treat that, that can potentially avoid a surgery down the line.
Absolutely. So that's where that rapid or early detection is very important for sure for long term. So the last topic I wanted to ask you about today is peripheral retinal disease. And I'll be honest, this was not something I was super familiar with. I looked it up to learn a little bit about it before we chatted today. So can you tell us a little bit more about what does this mean, peripheral retinal disease, and what's sort of happening in the retina in this group of conditions?
Yeah, so yeah, in the periphery of the retina is actually where most retina specialists spend a lot of their time, because as I mentioned, there's many diseases that start off there, such as a retinal detachment, for example. And so it's more of a description of the where the anatomy is. So as we had mentioned, the macula is the center of the retina. So if you think of the eyeball, all the images get focused into the center of the retina called the macula, and that's again responsible for sharp vision. Outside of that center area would be called the periphery. And so a lot of disease can start there, as I mentioned. And so a lot of my clinic visits are there to closely examine the periphery to see if I can see any precursor lesions that, and if identified, we can maybe avert or avoid kind of more serious downstream effects. One common thing, as you mentioned, is a retinal tear or retinal hole or areas of weakening that could potentially put someone at risk for retinal detachment. That's in the periphery. Diabetes, there are some presentations where predominantly the bleeding that we mentioned presents in the periphery. There are other diseases that are mainly confined to the periphery initially, such as sickle cell disease. So patients with sickle cell disease, they also can suffer from a retinopathy, and typically it presents in the periphery. Another thing I'll mention about that is that we have, along with therapeutics, and in parallel, what's been developing for eye care is imaging. And we have very effective imaging now, very quick photographs, for example, that can reach far out there. And so it's really allowed us to identify disease early and subsequently treat and intervene early.
Yeah, absolutely. So when I was reading a little bit about peripheral retinal disease, it looked like there were sort of different types or subtypes that kind of fit into this more umbrella category. Could you explain what some of those are and maybe some of their symptoms? Are they common symptoms? Are they different? What sort of diseases fall under that umbrella?
Yeah, that's a great question. I think it starts with, what does the periphery of the retina supply? And so the periphery supplies peripheral vision. So let's say this area is the macula, and then everything out here is the periphery. It also supplies night vision. And so a lot of the diseases, so for example, if it's just a small area, let's say a retinal hole, retinal tear, you're not necessarily going to have symptoms of decreased peripheral vision or decreased night vision. Now, if the retina starts to detach in the peripheral area, you would. There are diseases that predominantly affect the periphery first. Would include one that comes to mind is the most common inherited retinal disease called retinitis pigmentosa, and this is where the rods or the cells that supply the night vision degenerate. And so what I see in the periphery, and so if you just saw the center early on, at least, you may not see any abnormalities. But in retinitis pigmentosa, you see these areas of pigmentation in the periphery. And functionally speaking, a patient may notice that nighttime, or they tend to avoid the nighttime. They tend to avoid the nighttime, and they tend to be in very well-lit rooms because the peripheral function has been diminished.
So are there treatments for some of these peripheral retinal conditions? And if so, what does that look like?
It definitely depends on what the underlying disease is. If it's related to a hole or a tear or areas of thinning, I offer a treatment laser to basically close off these as a preventative treatment to decrease the risk of retinal detachment down the road. If it's related to a vascular disease, so we mentioned sickle cell retinopathy, that's treated with laser as well. And then if you're talking about inherited retinal diseases, we don't have necessarily a specific disease for retinitis pigmentosa, but characterizing a disease is the first step. It can lead to a lot of potentially intervention, and even though there's no necessarily any treatment today, characterizing that condition will, number one, provide a patient with more detailed description of the outlook, for example, and maybe even if they're interested, they can be eligible for certain research studies. So I still think, even though we don't necessarily have some treatments for certain conditions, I think, based on a patient's desire, if they want to learn more, I think that's always a good thing, to learn more about their condition.
Absolutely. I think that, well, that's what we try to do here, right? The more you know, the more power you have in terms of, making sure that you're staying on the right track. Well, thank you. I think that was the end of my questions today. So I'm going to turn it over to see if we have any audience questions. So again, just as a reminder to everyone out there, you can share with us your questions either in the Q&A box that is on your Zoom taskbar, or you can send us an email. And I think I have a couple here in my email, so let me just check really fast. Oh, this is a good question. So one of our viewers is wondering, is there research or ways that scientists are trying to make it easier for people to access diabetes screening?
That's a fantastic question. I agree, because prevention can avoid a lot of the complications, a lot of the downstream effects, and a lot of the patients' conditions that I see. And so definitely there are many groups looking to leverage teleophthalmology. And so, as I mentioned, that one of the major advancements in the last few years for the last few decades has been the imaging that we're able to do. And so there are some groups or many organizations that are looking to leverage these cameras to screen eyes in patients that are in more resource-stricken areas. I believe there is a service in Ontario. I think what would be important is maybe speaking to you afterwards in terms of having that on a link later on. But I do believe that there is. But just to let you know, like many people have thought to utilize the power of images and kind of relaying those images to a physician to diagnose. In my fellowship, there was a very good program in place to screen people with resource-stricken areas, and it was a very effective modality to get people in, because especially for diabetic retinopathy and diabetic eye disease, early on, there's no symptoms. There's no symptoms, and someone can be just, however, when there are symptoms, many of them can be permanent. So I echo the importance of that underlying fact that prevention is very important, and we have to find ways, innovative ways to capture people earlier on in their disease state so that we can intervene and really change the outlook for many.
Sure. And I think, if there is to be a silver lining of some of the things that have happened in the past couple of years in regards to the pandemic, I think the one thing I often think about is just the access to care has changed in terms of telemedicine, having access to Zoom, phone appointments, and just the general level of comfort that people have with that now, which we never had before, which definitely I think can help and apply in some of these more remote communities as well.
Mm-hmm.
We have another question here in the Q&A, and I know that I saw on your bio as well that you also do cataract surgery, so I think this is a good one for you as well. And Jessie Ann says that her mom needs cataract surgery that is overdue, and she's asking, can she be lightly sedated instead of being put right under? Can you talk a little bit about, what happens in a cataract surgery in terms of anesthesia?
Yeah, for sure. And there's a spectrum of anesthesia that can be used. And so not knowing the underlying medical history, I do want to reassure this audience member that there are many techniques to lightly sedate someone for cataract surgery. And that really has also been, not only has there been advancements in cataract surgery, but advancements in anesthesia and very topical, non-invasive methods. And yes, there are definitely options. Mm-hmm. In terms of the process, I mean, cataract surgery these days is a outpatient procedure. It's a day surgery. It typically, from the time you check in to the time you leave, is maybe about 2 hours or so. The surgery in typical cases can take about 10-12 minutes, 10 to 15 minutes per eye in typical cases. And the outcomes are very, very good in typical cases, yes.
I know when I talk to people who are nervous about having cataract surgery, I always tell them, like, this surgery's been going on for a long time. And famously, like, the Impressionist painter Claude Monet in like 19 something had cataract surgery. So we've had a long time to really hone in on the method for cataract surgery. And
sure.
thankfully, it's generally very, very safe. What else was I going to, the other thing I was just going to mention too, and again, I speak only from Ontario because we're here in Ontario, but I know also in terms of access to diabetes screening, I believe that to go to your optometrist to get an eye screening if you have diabetes, it is covered by OHIP in Ontario anyway, and I'm not sure about other provinces, but that's something to investigate too if, the financial piece is a barrier. Mm-hmm. Those exams are covered here in Ontario. Let's see, I think I have maybe one more question on here. And if this is your last call for questions out there in the audience. So my email, I do have a question about, the person here is asking, are you involved in research? What kind of research is interesting to you?
Anything that involves eye care. Specifically right now, I'm working on kind of new and novel methods to treat diabetic retinopathy, because that really is kind of a passion of mine. And there have been many kind of routes that I'm kind of taking. So right now I'm working on a potential novel medical device. Other things I'm working on is being part of clinical trials, and that really does inform how we as practitioners treat diabetic eye disease. And so Those are kind of the two things that I'm actively being involved in. And events like this, and I think it's very important to continue to educate, continue to inform those about the importance of screening, the importance of early symptom recognition. I think those go a really, really long way before they have to see me.
Well, I think that's so wonderful. Oh, we have another question. I was gonna say it was a good way to end, but we do have another question. Jessie Ann has another question. So she's asking, what is your opinion on natural supplements?
Natural supplements. I mean, I think that's a pretty broad statement, but I would say that when we talk about diabetic eye disease, there are the metrics that at least we can measure. If you're working towards lowering blood glucose, and with whichever safe way is there, and there certainly are many safe ways to do it through natural means, then all the power to you. I think really one of the foundations to diabetic eye care, even before medications, is lifestyle modification. And so this means a combination of exercise as well as what you consume in your body. In terms of specific evidence, in terms of a very specific natural or homeopathic or herbal medication, I think I would probably encourage looking into the exact research in terms of how that can, number one, improve your blood sugar, and number two, whether or not that has a direct effect on eye disease. But I think that definitely the general sentiment of the importance of knowing what you're consuming within your body and keeping a healthy lifestyle really is a very, very strong mainstay within diabetic eye care and diabetic care in general.
That's great. Thank you so much. Well, I think we will leave it there. We're right at 4 o'clock. And I want to thank you, Dr. Yau, for being here and for sharing that with us. I am 100% in agreement with you that I think what we try to do with these webinars through Fighting Blindness Canada is to help educate people, to inform people so that they have the best information that they can about their eye conditions. And again, just knowing what to look out for and making sure that we're going to the eye doctor regularly just to keep on top of everything. So thank you so much for being here.
Thank you so much for the invitation. It really was a pleasure. Thank you.